video is on the cardiovascular physical exam. We will go through the main steps, what you should be looking for, and what each findings may mean in terms of underlying pathology. As with all physical exams, you first start off with general observation. So for the cardiovascular exam, it's most important to look at the body habitus. Are they obese? May they have hypertension and heart failure? Or are they tall and skinny and have Marfanoid syndrome, increasing the risk of aortic regurgitation or aortic dissection? Also observe the bed. What is the angle of the bed? How many pillows do they have? As this may be suggestive of orthopnea, consistent with right heart failure. As always, then start looking peripherally and work centrally. So start off with looking at the hands. Is there any clubbing? Is there splinter hemorrhages as shown in this picture? Or Osler nodes consistent with infective endocarditis? Then assess the pulses. Assess the radial pulse. You're looking at the rate. Is it tachycardia? Is there bradycardia? Assess the rhythm. Is it regular? Is it irregular? And then assess the character. Is it weak or do you have a good, strong pulse? Then assess for radial delay, because if it's there may be stenosis on one side, for example, a subclavian or brachial artery stenosis. Or, especially in the pediatric population, assess for radiofemoral delay, consistent with coarctation of the aorta. Then assess the blood pressure. Now, most of the time it's very good, very accurate, but if you are doing it manually, it's less accurate in extremes of blood pressure. So if it's very hypo or very hypertensive. And the solution would be to have an arterial line in. And this is never something you do in an OSCE, but if they're critically unwell, it's something that maybe ICU or anesthetics would do. It's also not too accurate if the patient has an arrhythmia. Then look in the eyes for arcus caenalis, consistent with hypertension, or xanthellus mater, consistent with hypercholesterolemia. Look for any high arched palate, as this is consistent with Marfan syndrome. Then assess the carotid pulse as well as auscultate for bruits. Now, there are many causes of carotid bruits, but the main ones are carotid stenosis if it's unilateral, important because there are the increased risk of stroke, or if it's bilateral, aortic stenosis. Then look to see if the JVP is raised as in this picture, and you can also know the different parts of the waveform of the JVP, as this could further indicate underlying pathology, but we will not go into it because it's quite niche. Then you can finally look at the precordium or the chest. So ask the patient to take off their shirt. First, as always, observe, are there any surgical scars? For example, a median sternotomy scar if they've had a bypass, or a lateral thoracotomy scar if they've had a mitral valve replacement. Look for any distended veins as well as an apex beat. Then palpate the apex beat. If it's usually around the nipple, but if it's further left, it could be due to hypertrophic cardiomyopathy. When you're palpating the apex beat, also see if it's pressure loaded, volume loaded, or if it's dyskinetic. Then assess for thrills and heaves, consistent with valve disease. Finally, we can auscultate the heart. We will talk about the heart sounds and then murmurs. So there are two normal heart sounds, S1 and S2. S1 is heard when the mitral and the tricuspid valve closes. S2 is heard when the aortic and pulmonary valve close. Between S1 and S2 is systole. S1 and S2 are normal, as you can imagine, because these valves have to close at some point. S3 and S4, however, are pathological. S3 is due to ventricular failure. If it's on the left ventricular failure. If it's heard on the right ventricular failure. S4 is suggestive of hypertension, left systemic hypertension, on the right pulmonary hypertension. Also auscultate for splitting. Increased normal splitting could be suggestive of a right bundle branch block, heard loudest during inspiration. Fixed splitting could be an atrial septal defect, and reverse splitting is heard loudest in expiration, consistent with the left bundle branch block. Finally, we can get to murmurs. Now, there are many different types of murmurs, but we'll focus on systolic murmurs, as those are the most important. So aortic stenosis is an ejection systolic murmur or a crescendo decrescendo murmur, as shown in this schematic. So it gets loud and then it gets softer. It may also radiate to the carotids. Mitral regurgitation is a pansystolic murmur and is fairly equal in terms of its loudness throughout systole, unlike aortic stenosis, as shown in the schematic. It may also radiate to the axilla. Thank you for watching. I hope you learned something. If you did, please tell a friend who may also find it useful.